Chiropractic x-rays are absolutely essential to treatment in our office. And the reason for that is that they give us an overall view of exactly what's happened to you as far as the spine is concerned, what kind of activity you've had, and if you've had an auto accident, the point of impact on that injury, whatever kind of deterioration that we spoke about earlier is going on in that subluxation degeneration pattern, what particular phase that you're on. And what we're looking first in the films, and these films are taken mostly in an upright position because we're interested in having the actual postural study done. What is happening when the vertebrae is being compressed under weight bearing as opposed to lying down? Now sometimes we have to do films like that, and mostly the extremities are done on a tabletop rather than in an upright position. But for the overall spinal column, we want these in an upright position, weight bearing, so we can see what actually gravity is happening to you, and also what's happening basically with the muscle pull, which is a very, very important component of this. The first thing we look for is pathology. Is there any pathology going on in this spine or in the soft tissue, in the lung area, lumbar area? And so far on this particular film, what we're looking at is some arthritic pathology in the lower lumbar area. This would be tantamount to the phase 3 that we talked about earlier, where we're beginning to see it start fusing together. The disc is dehydrated. We've got some encroachment of the nerve root where it comes back in that intervertebral foramen. So we know that this particular lower spine is not a healthy spine, is in trouble and needs immediate care. And we'll get into the actual care in a little bit on that one. We also notice that the biomechanics of this spine are not correct. We have a central axis line on which the spine should be. The whole thing is shifted to the left. So we now have a situation where the entire rib cage is accommodated to that. We come over to the lateral cervical or the side view of the neck over here. We notice that there's some degeneration also going on up in here. Some lipping and spurring is beginning to happen. There is what we call an extension subluxation, where that particular vertebrae has come back on the one below it. And that again is occluding or making that opening narrow where the nerve root comes out. So we have a direct nerve pinch. That's a typical example of arm pain, numbness and tingling that can take place, and a potential disc problem that is either now or will exist at that particular point. We also notice that when we look at the overall spine, because this is shifted to the left, we know that the trapezius muscle on the right side is working harder than the one on the left. Part of the rehab program we're going to be doing will be to balance all of this out and make that spine come in on its straight axial plane. We also notice on the lower lumbar film that the fifth lumbar is not riding right on the sacrum. It's back too far, which coordinates with the lateral view. It is back too far, so we're going to have to reconstruct that forward and line that up in an axial plane also. These are called plane films. They give us a lot of information. If we need to go into more information as far as what the disc is doing itself and some of the soft tissue, we would then switch to what's called an MRI, have an MRI study done. This will actually give us a top-down view of the spine itself, so we can tell where the disc base is coming out. If we've got any protrusion actually into the nerve canal, we can tell whether we've got any protrusion that's coming into the cord itself, and whether or not this patient needs to be considered as a surgical patient. So this would be the last step in this office before we would go on to a surgical referral. After an extensive case history which tells us about the past, the next thing we want to do is do a physical examination. And the first part of that is a range of motion to determine whether that patient can freely move through what is called the normal plane without any restriction, without any pain, and without neurological involvement. In the neurological part of the exam, we stimulate the tendon of a muscle, which sends an impulse all the way back up to the spine and right back out again. And what should happen is we should have a contracture of that muscle. If there is no contracture, then we know that particular nerve root is being compressed. Another situation that can occur is the muscle will respond way too fast, and that's called hyperactivity, and that means that that nerve has now become too irritated and responds in a like manner. The next area of the exam is called the palpatory part, and by that I mean we're going to physically feel the areas of the spine, and I'm looking for taut and tender fibers, like that. I'm looking for areas of inflammation where there's pain. I'm looking for areas of hyper or hypomobility, and by that I mean areas that move too much or too little. And after all of that's correlated, we'll be leading into the actual biomechanical correction of that area that is not in proper alignment. Once we review the case history and go over the physical exam and x-ray findings, the next phase is the treatment phase, and that involves the actual manual manipulation to correct for those biomechanical faults. And that's done by a simple application of a force with some leverage to make the correction that's necessary to restore it back to being sound again. There are many techniques that are available. I prefer two in this office that I use most of the time. One of them is the manual, which you've just seen, and the other is called an activator. And the activator is a system that uses a 10-ounce recoil that allows us to make the correction without having to go ahead and physically move that with the pressure as you saw in the previous one. I prefer to use this on elderly people who are osteoporotic, children, or those individuals who don't like the audible sound of manual manipulation. Acupuncture is an important adjunct in our treatment at the office. We do both the traditional acupuncture, which is treatment of organs, as well as to use it, as I'm going to use it now, as a source of pain relief. As the acupuncture will release the endorphins and enkephalins, which are your own natural painkillers, in order to take the pain out of the area. And there are several ways to do it. One is with the needle that I just showed you. Another one is to use the teishin, which is a Japanese innervation, non-punction. We could use a cold source laser, high intensity light beam with electrical stem. Or in the case for arthritic patients, they can simply go through the area, stippling with the table fork and hit the same points. This they can use at home when they can't be here at the office for those chronic conditions.